I'm going to talk about some new and exciting developments in the treatment of myasthenia gravis that has reinvigorated the field. We all know about the complement inhibitor, eculizumab, that was released recently for refractory myasthenia gravis. And now Fc receptor inhibitors are being developed. I will just disclose that I'm a consultant for a lot of companies who've developed both, as well as immunoglobulin products. You've seen a little bit about the underlying mechanism of disease that has been provided to you by Nick Silvestri, but we know this is an antibody-mediated disease, myasthenia, and that there's a loss of tolerance with production of abnormal antibody. And we know that acetylcholine receptor is fundamental in neuromuscular transmission for activation of the postsynaptic membrane and muscle contraction and our strength. And we know that various other elements of the neuromuscular junction are important in the function and activity of acetylcholine receptors. So if we produce antibodies against this acetylcholine receptor, what we can see is that the abnormal antibodies interfere with the acetylcholine receptor in several ways. One, by simple blocking of the acetylcholine receptor. Two, by modulating the receptor, by cross-linking, leading to accelerated internalization and degradation, and by complement-mediated destruction. So these are the three main mechanisms, as you know. And if we go on, eculizumab, which has been approved, is effective at the last element of acetylcholine receptor dysfunction, where complement is split and you get the development of membrane attack complex and destruction of the postsynaptic membrane. So this complement inhibitor interferes with the release of complement and the complement activation. And you can see the blocking, and you can see the complement recruitment. What we're really going to talk about now are Fc receptor inhibitors. The Fc receptor functions to recycle immunoglobulin. The IgG binds to the Fc receptor and it's recycled. You have the binding and then the recirculation to the cell surface membrane. If you inhibit an Fc receptor, it reduces recycling of immunoglobulin and it delivers the immunoglobulins to the lysosomes where they are degraded. So in effect, it drops IgG levels and it drops all classes of IgG if you're treating with an Fc receptor inhibitor or exposing the patient. So what you're doing is blocking a recycling mechanism that helps maintain immunoglobulin levels in the circulation, including abnormal immunoglobulin activity such as acetylcholine receptor antibodies. Fc receptor inhibitors, what happens is you block this recycling and you block the antibody, reduce it, and therefore all the mechanisms of an abnormal antibody that we reviewed are reduced. All the IgG subclasses from 1 to 4 are removed, and therefore you can expect this type of therapy to work in acetylcholine receptor positive myasthenia gravis, but also in MuSK myasthenia, where MuSK is IgG4. And as you recall, complement is not activated by IgG4, and so complement inhibitors cannot treat MuSK-MG. So Fc receptor inhibitors would be able to treat all. The ones that are in development are Efgartigamod, and the phase 3 trial was positive and published in July 2021 and has been approved by the FDA for use in generalized myasthenia gravis. Rozanolixizumab has completed phase 3 and positive top-level results were announced by UCB in December 2021. Nipocalimab and the Immunovant product have been positive in phase 2 studies and are still under development. but not yet as advanced as the other two. So here, Efgartigamod, it just repeats the mechanism of action. It is a fragment, not the entire antibody, and has increased affinity at different pH values. So it has a half-life as shown there, and there's a targeted reduction in IgG subtypes. The study that proved the efficacy of this was a phase 3 study with Efgartigamod given every week for 4 weeks, and then a repeat cycle allowed. And a placebo group was obviously given placebo. The primary endpoint was based on the first cycle treatment, in acetylcholine receptor positive patients. The benefit in this study is that patients with MuSK positive MG and also seronegative for both were allowed to enroll. After the phase 3 study, patients were allowed to enter an open label extension for up to 3 years of treatment. So this was an individualized treatment. You see 2 cycles, but the second cycle was only administered if the effect of the first cycle wore off and patients deteriorated on their activities of daily living, the ADL, so that you had to clinically deteriorate to get the second treatments, but that was not the primary endpoint. And this just shows the patients, the overall population, and the acetylcholine receptor positive patients, very similar in age across the groups and in MGFA classes and in their therapies. You can see that 70 to 80% had been on steroid at some time, and a minority or fewer patients had only been on acetylcholinesterase inhibitor therapy. And you can see the patients, there were 19 that were not acetylcholine receptor positive in the drug group and 19 in the placebo group. So the numbers of these other populations are small. And this was the primary endpoint, was the ADL receptors to the left. You can see that 67.7% responded during the first cycle on Efgartigamod and 29.7% in the placebo. And then in the second cycle, the responder rate was 70% on drug and 25% on placebo. And this just shows you graphically as well that there was an effect in both cycles, so the response was repeatable. It was only the first cycle that was used for submission for approval to the FDA, and there was enough evidence from that to allow approval. And I think just to show that the mechanism of action of reducing IgG and acetylcholine receptor antibodies was effective. You can see the maximum reduction was by 4 weeks, but the reduction started by the first week. This drug is given intravenously, and there was a significant drop-off in both the total IgG population and the abnormal acetylcholine receptor antibody at week 1. The albumin levels did not change, and that's an important consideration as one of the agents may slightly adjust albumin levels. And the overall population of, had similar reductions in IgG. And this is the Christmas tree plot, which is a favorite way now of showing benefits of treatment. To the right is placebo. What this shows is that as you increase the rigorous cutoff values for the ADL and increase the cutoff values for the QMG, that the placebo responder number drops and the drug group is maintained, so that the benefit in the drug group is shown with greater degrees of change. Minimal symptom expression was achieved in 40% on Efgartigamod and only 11% on placebo. And this was those people who achieved an ADL of 0 or 1 anytime during the first cycle of treatment. Now, the other interesting thing is how long the response lasted. In about a third of patients, the response lasted more than 12 weeks, although you might have expected some recovery in IgG by then. In 20% or so, 8 to 12 weeks, and in a very small number, it was less than 6 weeks. This difference in duration is a reason to individualize treatment and perhaps retreat as the patient notices a worsening. That may be one approach, because you're not quite sure how long the effect will be in any one patient. It's not a standardized duration of benefit. And we'll go to now the secondary endpoint overview. And what is important is that multiple secondary endpoints showed benefit of Efgartigamod over placebo, including the quantitative myasthenia gravis score improved 63% on Efgartigamod, 14% on placebo, and the duration of the more than 2-point improvement in ADLs was longer with drug than placebo. The early responders higher on drug than placebo. So really multiple endpoints showed benefit with drug over placebo. It was not a simple endpoint. If we look at this in the seronegative, now we're down to smaller numbers, 19 and 19. It gets harder. There was no difference in ADL responders, which was interesting. But on the quantitative myasthenia gravis score, which is a more objective measurement of strength, there was a greater percentage on drug than placebo. And then MDL responders and QMG responders, if you wanted both to meet the definition of response, this was definitely more evident on drug than placebo. And then minimal symptom expression, again, more common in drug, but the numbers are getting too small to really make a lot of inferences from. And if we look at the side effects, they were similar between Efgartigamod and placebo. They were mild to moderate and well tolerated and easily treated. The most frequent was headache in both groups, nasopharyngitis in both groups, and then you can see the rest. Infusion infections were slightly more prevalent in Efgartigamod than placebo, but not by a large number. And infusion events were actually more marked in placebo. If we look at this in summary, about the same percentage of patients in each group had AEs, serious ones, similar, but maybe more in placebo, and discontinuation from this study because of AEs was the same in drug and placebo. So really, Efgartigamod was generally well tolerated by patients in this phase 3 study. Now, Fc receptor inhibitors are not the only drug. As I've mentioned, we have complement inhibitors. You've heard about B cell reducers such as rituximab. And I think it's important to remember that with complement inhibitors, MuSK antibodies do not go activate the complement pathway, do not go that way. And therefore, complement inhibitors would not work in MuSK-positive patients. Again, the underlying antibody production is not altered, and you may get rapid return of symptoms. The trouble with B cell depleters is, or anti-CD20, this is not expressed on early B cells, precursors, or late stage long-lived antibody producing plasma cells, which are predominant in acetylcholine myasthenia, do not respond to this therapy. And this may be why only about 1 in 3 of acetylcholine positive patients has shown benefit with rituximab, and why the evidence is so inconsistent. It is very consistent for MuSK, but not so consistent for acetylcholine receptor MG. The other things are administration, IV, and then the costs. And then finally, this just shows that there are multiple places to attack with different therapies. And as we go, this is this diagram of immune issues in myasthenia. And as we go more upstream, so complement is at the end where you're destroying the postsynaptic membrane with the abnormal antibody. And as we go more proximally along the cycle, we get more selective and more specific. The cure really is to turn off the abnormal antibody production, and we are not there yet. I just want to mention the other Fc receptor inhibitor. Efgartigamod is intravenous. Rozanolixizumab is subcutaneous. Rozanolixizumab, as I mentioned, just announced their high-level positive phase 3 results in December. They will be showing at upcoming meetings, but they showed some changes in their phase 2 study that led to the phase 3 program. So there were positive changes, particularly with 7 milligrams per kilogram administered in 2 cycles of 3 weekly cycles, the first one, and then after the second one. And rozanolixizumab also drops, as you can see here, the antibody levels that are shown in orange and the total IgG, and you can see that it happens, and it starts to happen within the first week, but the nadir is seen at day 36 during dosing period 2. So Fc receptor inhibitors are a promising novel treatment. There's a lot of active investigation, as I've shown, and the benefits that we predict are that this may be used in place of plasma exchange, intravenous immunoglobulin, and subcutaneous immunoglobulin. The onset is rapid within the first 2 weeks or 3 weeks of therapy, a little more rapid if it's IV rather than sub-Q, but still fairly rapid, and shows benefit on multiple endpoints in myasthenia gravis. So it will alleviate some of the access issues with PLEX and maybe better tolerated than IVIG or sub-Q IG with lower volumes if you're administering it either IV or sub-Q, and less issues with the possible shortage of immunoglobulin products. So it's a very exciting time.
My relationship with Dr. Bril as my neurologist has been very important to my understanding of the disease when I was first diagnosed, my treatment options at the beginning, and she's the one who guided me through the crisis that I had the year after I was diagnosed. When new treatment options become available, we talk about them to get a sense of what works for me and what doesn't. And in particular with Dr. Bril, I understand that her goal is not to over-medicate me. Her goal is to find the appropriate level of medication that lets me lead the best life that I can lead without overexposing me to the side effects of medication. And it's a very delicate balance. And it's something that we'll probably continue balancing for the rest of my life.